Now today's topic of discussion will be pre-anesthetic evaluation. Now in pre-anesthetic evaluation, we have to see and take into consideration many things before we take any patient for any kind of surgeries. From general examination, from his present complaints to his systemic examination, all the investigations and the airway examination as well is of utmost importance in a patient whosoever is going for any kind of surgery, be it emergency surgery or any kind of planned surgery. So for making this clear for every anesthetic, some guidelines were made, some baseline guidelines were made so that every patient was ranked in the order of its severity of the disease and for the cause for which the patient is going operated. So basically there was one society named as American Society of Anesthesiologists who described or differentiated different patients into different categories, and according to that the patient's condition and his or her recovery was dependent. So we will firstly classify the patients depending on ASA criteria, that is American Society of Anesthesia, which divided the patients from ASA 1 to ASA 6 depending on the severity of any kind of comorbidities the patient has. ASA 1 being a patient with no comorbidities and so on and so forth. So we will write down the classification with some examples which will make clear to you that what is basically the criteria, right? So pre-anesthetic evaluation is the topic. ASA classification, definition of that, and examples for each and every grade, right? So first it is ASA grade 1. Now what is ASA grade 1? For example, a patient is coming for a routine surgery, maybe hernia, hydrocele or fibroadenoma, some kind of uterine prolapse. When do we say a patient is ASA 1? ASA 1 means the problem is just localized. The surgery itself is the problem to the patient and nothing else. So in ASA 1, the localized problem, if treated, the patient becomes healthy again. So in ASA 1, the patient is absolutely normal. That is healthy, non-smoking, no or minimal alcohol consumption, right? So this is ASA 1 classification. Now we move on to ASA 2. Now what is ASA 2? For example, a patient comes to you and says, and you ask him, do you have any past medical history? Do you take any kind of medications for that? The patient replies, sir, I have bronchial asthma, but I don't take the medications frequently because I am able to do my day-to-day work without any hampering. I am able to walk 2 to 3 miles. I am able to climb 3 to 4 stairs. So that is not an issue for him. So in ASA 2, the comorbidity is very, very self-limiting, right? So in ASA 2, mild, that is mild systemic disease. Mild systemic disease. Now what are the examples of these? Mild systemic disease, the examples can be, firstly, there is no substantial functional limitation, right? I told you that the patient is able to do his or her work without any limitations. The patient is able to walk 5 kilometers without any problem. He is able to climb 3-4 steps without any difficulties. So no substantial functional limitations. A smoker, a patient who has been smoking, is considered under ASA 2. Now pregnancy as well. Pregnancy as well comes under ASA 2. Now BMI also plays a part. BMI also plays a part, that is 30 any patient between the range of 30 to 40 BMI is considered as ASA2, right? And I told you controlled systemic disease like diabetes mellitus, hypertension or bronchial asthma. The patient has controlled diabetic mellitus, hypertension and bronchial asthma. Now we move on to the third grade, that is ASA3. Now what is ASA3? That is severe systemic disease. Severe systemic disease. Now what does this mean, severe systemic disease? This means that the patient has substantial functional abnormality. The patient has substantial functional limitation. Other examples in ASA grade include one or more severe disease like bronchial asthma supplemented with COPD or hypertension or diabetes mellitus. So, one or more superadded diseases, poorly controlled diabetes mellitus, hypertension, BMI more than 40. In ASA grade 2, we had less than 40, but in ASA grade 3, BMI is more than 40. Morbid obesity, and also end-stage renal disorder patients on dialysis. Right? The patient is undergoing regular dialysis. So, in ASA grade 3, the patient has severe systemic disorder and the disability is leading to functional limitations of the patient. The patient has one or more superadded diseases, poorly controlled diabetes, hypertension, morbid obesity and BMI more than 40. Any patient on end-stage renal disease but taking dialysis regularly. Now what is ASA grade 4? ASA grade 4 is severe systemic disease which is a constant threat to patient's life. What does that mean? A patient of ASA grade 4 has severe systemic disease which is a constant threat to patient's life. That is, if the patient has not been taking his medications, absolutely not. The patient did not take any medications. He was diagnosed with some systemic disease, but he just didn't take the medications. So, in ASA4, the examples we set as a patient who has recent MI, cardiovascular accidents or something like that, the patient is considered under ASA4. So, examples are recent MI, CVA, cerebrovascular accidents, transient ischemic attacks, decreased ejection fractions, DIC, and ESRD without dialysis. ESRD without dialysis. That means the patient condition is a constant threat to his present condition. For example, this ASA4 patient is coming for any kind of surgery, be it hernia or anything, but the patient had recent MI or CVA or transient ischemic attack. Echo revealed ejection fraction of 20 to 25%, or the patient is end-stage renal disease CKD on dialysis, the patient is considered under stage 4, right? Now what is stage 5? Stage 5 is very easy to understand. The patient cannot survive with the surgery, without the surgery, sorry. The patient cannot survive without the surgery. So, the patient is moribund, can't survive without surgery. Now, the examples of these are ruptured abdominal or thoracic aneurysms, right? These conditions are life-threatening. So these have to be operated immediately, be whatever the condition of the patient. The patient cannot survive without surgical intervention. Now further examples are massive trauma leading to excessive bleeding and intracranial bleeds. These patients, whatever may be the condition of the patient has to be taken for surgeries, and the patient cannot survive without the surgical intervention. Now the sixth point is brain dead patient. Brain dead only for organ harvesting. That means the patient has expired and his organs are being utilized to save the life of another patient. So these are the 6 ASA criterias. Now why these criterias were made? For example, I am inside a OT and I am doing a case, and another anesthetist comes to the OT and asks me about the patient. What is the case going on? What is the present scenario of the patient? What are the drugs I have used? And the history of the patient as well. Now, till the time he asks me, I just tell him that the patient is ASA grade 2 and the patient is being operated for umbilical hernia under spinal anesthesia. Now, I have just collected all the information into a very small classification, making it easier for another person to understand that all the history has been summarized and the patient has been classified under ASA 2. Now, another example can be taken. Another anesthetist comes to the OT and the patient is being operated for ruptured thoracic aneurysm. Now, what is the criteria? Even if the patient was 45 years old or 50 years old, I tell him, sir, the patient is ASA 4 and the patient is undergoing such and such surgery under general anesthesia. He will understand that the patient is critical according to the ASA guidelines. Each level increasing from 1 to 6, the criticality of the patient increases, right? Now, one more thing, whenever any ASA is added on with an E. Now, what does this E depict? This E depicts emergency. This E depicts an emergency. Now, for example, a 30-year-old male went outside and had a road traffic accident. He broke his leg, his femur was shattered, and the patient had to be operated on emergency basis. Now, the patient did not have any kind of comorbidities, so the patient was taken under ASA 1E because he needs to be operated in an emergency, right? Now, moving on from ASA guidelines, some consents, some things have to be done pre-operatively and post-operatively so that we can evaluate the patient properly and give proper course of anesthesia and as well post-operative care to the patient. Now, in this we have asked the patient what was his or her comorbidities, any kind of medications he was taking, any kind of treatment he was taking, any kind of herbal medications they were taking. Why do we need to know this? Because every medication has his own importance on anesthetic drugs, on surgical course itself, so that we can understand whether we need to continue the medications till the day of surgery or we have to stop them some days prior to the surgery. Now, starting from the very beginning, when a patient comes for a pre-anesthetic evaluation, we make the patient sit down and ask him whether he has any kind of present complaints or not, whether the patient has fever or cough in the recent past. All these examinations are being done on a routine basis. No patient skips these routine examinations. Secondly, we move on to systemic examination like respiratory system, CVS, CNS, to see the condition of the patient, whether he or she will be able to tolerate the anesthetic procedure, the surgical procedure and the course of the patient post-operatively as well. Then we move on to investigations. Investigations like complete blood count, kidney function test, liver function test, PT-INR, serum electrolytes, chest x-rays and ECGs. So these things have to be looked into before giving any kind of anesthesia fitness to the patient, because if those things are escaped, we might land up into a big problem while giving anesthesia and post-operatively as well. Now amongst these is what for our anesthetist, airway examination is of utmost importance. Why? Because the patient might be requiring general anesthesia for any kind of surgery. For example, a patient is going for humerus neck fracture and we want to give, and the patient denies that he doesn't want to get operated under block, any kind of block. So we plan to give him general anesthesia. For giving general anesthesia, we need to evaluate the airway of the patient and then dignify some kind of classifications as well in airways, so that it makes us easier when the patient comes to the OT. So that is why pre-anesthetic evaluation is so important, because we assess the patient, because we should not be finding any problems while the patient is on operation table, right? So the next point is airway evaluation. Now what are the things we have to look in airway evaluation? First of all, we see is mouth opening of the patient. Mouth opening. Whether the patient is able to open his mouth properly or not, because we need to introduce laryngoscope. Then under direct laryngoscopy, we need to introduce an endotracheal tube. Secondly, neck movements. Neck movements. Thirdly, atlanto-occipital movement. Fourth, mentohyoid and mentothyroid distance. And finally, we move on to Malam-Patti classification. Now all these things have to be thoroughly looked into before giving any kind of fitness to the patient, because I told you, if the patient is getting operated under regional anesthesia also and something happens, we might have to turn that case from regional anesthesia to general anesthesia. So these examinations have to be done even if the patient is planned for a spinal anesthesia or regional anesthesia, because at any moment of time we might have to change to general anesthesia from spinal anesthesia, right? So why all these things are important? I told you that we have to observe the mouth opening, the neck movements, the atlanto-occipital joint, the mentohyoid and the mentothyroid distance, and the Malam-Patti classification. All these are airway examinations, so that it doesn't become difficult for us when we intubate the patient for general anesthesia. So now in this criteria, everything is important, but Malam-Patti classification is even more important. So there are different grades. There are different grades in Malam-Patti classification. Basically from grade 0 it starts. So we will write down in a very systematic way so that it becomes easier for you to understand. Firstly, I'll write grade 0. Now what does grade 0 mean? Grade 0 means grade 0. Even the tip of epiglottis. Even the tip of epiglottis is visible. The tip of epiglottis is visible. Now I'll make you clear, but let's first write them down. What are the different grades? Now we move on to second grade, that is grade 1. Now starting from the front of the mouth, first of all we see is hard palate. So hard palate is going to be visible in all the grades, right? So first is hard palate. Second is, then we move on to soft palate. After hard palate comes soft palate. Then it is fascial pillars. And finally, uvula. So, in grade 1, we can see starting from the front of the mouth, hard palate, soft palate, then comes fascial pillars and the uvula. Then we have grade 2nd. Now, just by common sense, we can realize these grades are decreasing in that order. So, in grade 2, uvula will be missing. No uvula will be seen. All the other 3 things will be seen. Hard palate will be visible, soft palate will be visible, and fascial pillars will be visible, right? Then comes grade 3. Now, grade 3 we have hard palate and soft palate. Uvula was not even visible in grade 2, so it won't be visible in grade 3 as well. So, we see that we cannot see basically fascial pillars as well. Now, we move on to grade 4. Grade 4, that means we only see hard palate, soft palate is even not visible. Now, why do we need this classification? Why do we need this classification? Because these 3 grades, above 3 grades and these last 2 grades tell us about the difficulty of intubation and about the size of the tongue as well. In grade 0, grade 1 and grade 2, it signifies small tongue. Small tongue meaning intubation is easier, right? In grade 3 and grade 4, the tongue size is large tongue, and intubation might be difficult. Alright, so these MPC classification even tells. Now, for example, I gave you an example that an anesthetist came to the OT. I told him that the patient is ASA 1 or ASA 2, and that gave a brief history about the patient. Now, while intubating, I asked for some kind of assistance from another anesthetist. Then he asked, what is the grade of the MPC? I tell him, sir, the grade is MPC 3. So he thinks that he automatically understands that it is going to be a difficult intubation because of the large size of the tongue and the apertures present in the oral cavity are not properly visible. After all the investigations have been done, all the evaluations have been done, a night prior to the OT, an anesthetist visits the patient and gives some kind of preoperative orders. Now, what are those preoperative orders? The preoperative orders consist of, example like NPO guidelines. The patient has to be kept NPO, nil per oral, for certain duration of time before taking a patient for routine surgeries. We cannot ask an emergency surgery to be NPO for 6 to 8 hours, right? So these guidelines are only for routine surgeries, which are planned surgeries. So NPO guidelines, any kind of pre-medications we have to give, any kind of medications the patient was taking. So we have to just see whether we need to continue the medication or we need to stop them. So pre-anesthetic orders, pre-anesthetic orders, right? First, the foremost important thing is the consent of the patient. Whether the patient needs to be operated, it's our choice. But whether he wants to get operated or not, it is his or her choice. So, the first is consent, right? The consent of the patient is of utmost priority. Now, the next point is NPO orders. NPO orders. Now, there are different guidelines for adult and pediatrics. So, here only I'll tell you about the different guidelines for adults and pediatrics just to make it easier for you guys, right? for adults and pediatrics, peds patient. Now 8 hours, 6 hours and 2 hours. Now what are these 8 hours, 6 hours and 2 hours? If a patient has taken any kind of solid food, it has to be for 8 hours NPO, solid food. For example, I tell the patient that you are going to get operated at 9 in the morning. So the last solid meal he can have is around 12 to 1 in the night. So that we can have NPO for 8 hours, right? Then we move on to 6 hours. Semi-solid food or liquid. The patient can have only up till 6 hours. Liquid in this scenario is any kind of juice the patient is taking or any kind of additive flavored juice which are present in the market. Patient can take those up to 6 hours. Now if the patient says, I just want to have clear fluids like coconut water, so those things come under 2 hours guidelines. So 2 hours for clear fluids like water or coconut water, right? Now in pediatric age group, 8 hours again for solid food. But then pediatric age group is considered below the age of 15. So some of them and even the patient who are in a range of 1 to 2 years might need some surgical interventions after birth as well. So the patient, the baby might be on breast milk or formula feeds, right? So those criteria have to be differentiated differently. Now for 6 hours again, for 6 hours this is 8 hours, 6 hours for formula milk, 4 hours for breast milk and 2 hours again for clear fluids. Now why breast milk and formula milk have been kept differently? Because breast milk gets digested pretty fast as compared to formula milk. Formula milk takes a bit more time as compared to breast milk to get digested. Now there is one more society of anesthetists in Great Britain and Ireland. Now they have modified the guidelines for clear fluids. They say that 1 hour NPO is sufficient for clear fluids. So that is by Great Britain and Ireland Anesthesia Society. Right. So till the time it is not mentioned in the questionnaire, according to Great Britain or Ireland Anesthesia Society, the answer for clear fluids has to be 2 hours, right? Now in this, after we have given NPO orders, the third point is pre-op medications and the fourth point is previous medications. Previous medications the patient has been taking for a long while. Now in pre-op medications, we might give some H2 receptor blockers, some antacids, some anxiolytics to the patient so that the patient does not have any kind of anxiety or any kind of acid reflux prior to the surgery, right?